What's up, everybody, and welcome to the Super Nurse Podcast. I'm Brooke Wallace, ICU nurse, transplant coordinator, clinical instructor, and creator of Super Nurse Comics. I personally research and clinically review every episode before our AI hosts bring it to life. With the latest research and best practices mixed up with my real-world experiences, we're going to help you be the super nurse you were born to be.
It's 3 a.m. on the unit. The lights are dim, the halls are really quiet, and a nurse is pulling a PRN, an as-needed pain medication, for a patient in room 4.
Right. It's a scenario we've all been in.
Exactly. But the pill that is handed to the patient isn't the narcotic they desperately need. It's just a plain Tylenol swapped out in the shadows.
And while that patient just lies there in bed, suffering and waiting for relief that, simply isn't coming, the nurse pockets the narcotic.
It sounds like a dramatic TV show scene.
It does, but it's a terrifying reality. It happens far more often than anyone really wants to admit.
Welcome to the Super Nurse Podcast, created by Brooke Wallace. Now, before we get any further, we should probably clarify right out of the gate that we are not Brooke Wallace.
No, we are not.
Yeah.
But we are taking Brooke's incredible clinical notes and her 20 years of ICU experience to guide this conversation.
Yeah, Brooke has been an organ transplant coordinator, a clinical instructor, and a published author.
So today, we are taking her signature ICU teaching style and bringing it directly to you. This is all about helping you, whether you're a nursing student or a brand new nurse bridge, that massive gap between textbook theory and real bedside patient care.
And make sure you subscribe and watch the comic book-based video for this episode on YouTube. The link is right down in the description, and the channel is called Super Nurse Comics.
Today, we're tackling a heavy but completely unavoidable bedside reality, right? Substance use disorders and drug diversion among nurses.
Yeah. We are going through exactly how it happens, the subtle bedside clues you need to watch for, the massive legal stakes, and most importantly, how to actually throw a lifeline to a struggling colleague.
So let's look at who is actually struggling first, because if you want to spot drug diversion on the floor, you have to throw away that stereotype of, like, a junkie on the street.
Right, that's not what this looks like at all.
Not at all. The research shows that the person diverting medications is often the highly competent, deeply respected charge nurse standing right next to you.
Which completely shatters the illusion. Clinical surveys indicate that up to 18% of registered nurses have reported problematic substance use at some point.
Yeah, it's a huge number.
And nearly 31% of publicly reported drug diversion incidents involve nurses.
But why? Is there something about the personality of someone drawn to nursing that makes them inherently more prone to addiction?
Well, the evidence actually tells us no. Nurses have about the same overall addiction rates as the general public, right around 10%.
Okay, so the difference isn't the person.
No, it's the environment. It's this deadly combination of incredibly high job stress, chronic exposure to vicarious trauma, watching people suffer and die on a daily basis, and then the ultimate catalyst.
The access.
Exactly. Unparalleled direct access to controlled medications.
It's like a chef developing an unhealthy relationship with food.
Oh, that's a great way to put it. Yeah, when you are just surrounded by the ingredients all day, the boundary between a professional tool and a personal coping mechanism can blur. You start seeing the drug not just as a medical intervention for the patient, but as a potential relief for your own exhaustion.
And the hospital environment acts as the ultimate enabler for that shift. Addiction is a primary chronic brain disease.
Right.
The hospital doesn't create the disease itself, but the sheer crushing weight of the job pulls the trigger, and the open access provides the ammunition.
But here's what I don't get. Nurses spend years studying pharmacology. We're tested relentlessly on pharmacokinetics, side effects, the extreme dangers of these drugs.
Oh, absolutely.
So how does someone with that much education fall into the trap? Wouldn't that knowledge be a deterrent?
You would really think so, but it actually works against them. Clinical experience shows us this phenomenon called the invulnerability myth.
The invulnerability myth.
Yeah, it's a textbook case of cognitive dissonance. Because nurses are so highly educated on how these drugs work, they know the half-life, the mechanism of action, the receptor sites. They falsely believe they can outsmart the drug.
Wow.
They tell themselves, I know exactly how to titrate this. I won't get injected because I understand the science.
So the education actually breeds arrogance in a way.
It breeds a false sense of control, yeah. They think they're immune to the biological reality of dopamine receptors, and by the time they realize they aren't, the addiction has completely taken over.
Okay, so if they are that smart and they know the systems intimately, catching them isn't going to be easy.
No, it's incredibly difficult.
Because when that addiction takes hold, they don't just grab a handful of pills from the pharmacy and run out the door. They use their insider knowledge to divert these drugs right under everyone's noses.
Which brings us to how this actually looks at the bedside. Diversion simply means the unlawful misdirecting of medication for personal use. And the methods are, well, they're incredibly sophisticated.
Before we get into the methods, let's talk about the medication dispensing machines themselves. In most modern hospitals, you don't just have a drawer full of drugs.
Right, you have automated dispensing cabinet.
Yeah, like a Pisces or an Omnicell. These are basically high-security medical vending machines. You have to log in, scan your fingerprint, select your specific patient, and the machine only pops open the specific drawer containing that specific drug.
It tracks everything.
Exactly. So how are they getting around a digital system that tracks their every move?
Because the system still relies on human execution at the end of the line. Take the waste loophole, for example.
How does that work?
Let's say you have an order to give a patient 1 milligram of hydromorphone, but the vial the machine dispenses contains 2 milligrams.
Right.
The proper procedure is to draw up the 1 milligram for the patient and then immediately dispose of or waste the remaining 1 milligram into a designated sink or bin with another nurse physically watching you do it.
Right. You need the physical witness.
Yeah. But in the waste loophole, the diverter gives the half dose to the patient, pockets the other half, and then later in the shift catches a busy colleague in the hallway.
Oh, I see where this is going.
They say, hey, I wasted that Dilaudid earlier but forgot to log it. Can you just sign in the machine for me?
And the trusting colleague just does it.
Yeah, they want to be a good team player. So they scan their fingerprint and sign off on a waste they never actually saw.
That is terrifyingly simple. You're leveraging the chaos of a busy 12-hour shift to bypass the digital security. What about the swap?
The swap takes it a step further and directly harms the patient. A nurse might take a syringe of injectable fentanyl, pocket it for themselves, and replace it with plain normal saline.
Oh, wow. So they inject the patient with the saline.
Yes, the patient thinks they are getting pain medicine, but they're literally just getting salt water.
Or they swap a hydrocodone pill with a similar-looking Tylenol in a dim room, have we talked about at the start of the show.
Exactly. And there's an even more dangerous version of this involving the bulk supplies.
What do you mean?
Let's say a nurse goes into the back stock, where the pharmacy keeps boxes of fentanyl vials. These boxes are often shrink-wrapped in plastic. A diverter might take a scalpel, slice a tiny, almost invisible slit in the side of the plastic wrap, slide out a few vials, and then forge the inventory documents.
So the box looks completely untouched.
Completely normal?
Wait, I remember reading about tampering with fentanyl patches, too. A fentanyl patch is just a flat, sticky piece of plastic that goes on the skin. How on earth do you pull a drug out of that?
It depends on the manufacturer, but many fentanyl patches have a small reservoir of active gel in the center.
Yeah.
A diverter will take a microscopic needle, like a tiny insulin syringe, pierce the edge of the patch, and extract the fentanyl gel right out of it.
Wait, really? Just pulling it straight out?
Yeah, right out of the plastic.
Uh-huh.
Then they apply that now empty patch to the patient's skin. It looks totally normal to the next nurse who assesses the patient, but the patient is receiving absolutely zero medication.
The ingenuity is just, it's like a reverse bank heist. Instead of a mask and a gun, they are using their hospital badge, a syringe, and their clinical knowledge as their cover.
That's exactly what it is.
But I want to circle back to something you said about the saline swap, because this is definitely not a victimless crime. Aside from the obvious horror of leaving a patient in agonizing pain, there's a massive infection risk here, right?
Oh, a massive risk. Think about the physical mechanics of how someone might steal a portion of a drug from a vial and replace it with saline to make it look full.
Right.
If the nurse diverting the drug has a bloodborne pathogen like hepatitis C, and they use a syringe to pull medication out for themselves, then use that same equipment to backfill the vial with saline.
They just contaminated the whole vial.
Exactly. They have just contaminated the vial. When that vial is used on a patient, the patient gets infected. We know from practice that this exact scenario has caused major multi-state hepatitis outbreaks in hospitals.
Okay, so if the methods are this invisible and the machines are being outsmarted by human trust, we can't just rely on catching someone in the act. No one is going to be injecting drugs in the middle of the nurse's station.
No, never.
How do you actually spot this?
You have to look for the subtle clinical and behavioral breadcrumbs left behind on the unit. You are looking for a pattern. In medicine, we use the word toxidrome, which is a specific combination of signs and symptoms that point to a certain type of poisoning.
Right.
Well, There is a behavioral toxidrome for diversion.
So what does that behavioral toxidrome actually look like?
Behaviorally, you are looking for the nurse who constantly isolates themselves from the team. They take frequent, unexplained, long trips to the bathroom.
Okay.
They have excessive, unscheduled absences. Or suddenly they become hyper-focused on working the night shift, specifically because there is less management, fewer doctors rounding, and less overall supervision.
And there's also the overly helpful colleague, right? This one feels like a trap.
It really is.
Because if I'm a brand new nurse, fresh off orientation, and I have 3 complex patients, I am probably drowning in charting. If a 15-year veteran ICU nurse walks by and says, "Hey, I see you're swamped," I can go push that morphine for your patient.
You're going to say yes?
Right. My first thought is, wow, I am so lucky to work with such a great team player. How do I tell the difference between a genuinely helpful coworker and someone who is diverting?
That is arguably the toughest situation for a new nurse to navigate because you don't want to question the veteran nurse who is throwing you a lifeline. The key is pattern recognition.
Okay, so one time is fine.
Right, one offer to help is teamwork. But if you have a colleague who consistently seeks out narcotic administrations for other nurses' patients, if they're always the one volunteering to hold the physical narcotic keys, that's a major red flag.
It's a clustering of signs.
Yes. You pair that overly helpful behavior with clinical clues. Are there frequent discrepancies in their opioid counts at the dispensing machine? Do they hold all their medication waste until the very end of the shift, instead of wasting immediately? And most importantly, are their patients constantly complaining that their pain medications aren't working?
Because they never actually received them. The patient's pain is the alarm bell.
Precisely. If you give a patient, 2 milligrams of IV morphine, you expect a real physiological response.
Right. Their heart rate should settle down.
Exactly. Their blood pressure should improve, they should relax. But if a specific nurse is consistently charting heavy narcotics and their patients are still writhing in pain...
And they're tachycardic and hypertensive.
Yeah, your clinical judgment has to kick in. Something is wrong there.
We also have to mention the physical signs, right? Like pinpoint or dilated pupils, sweating, chills, a constantly runny nose, or wearing long sleeves in the middle of a hot summer shift to hide track marks.
You do need to watch for those, but honestly, nurses are highly functional professionals.
So those signs show up later.
Much later. By the time you see overt physical signs like track marks, or they are actively nodding off at the computer, the addiction has usually progressed to a very late, very dangerous stage. The behavioral breadcrumbs almost always show up first.
Which brings us to the terrifying reality of what happens when the house of cards finally falls. Because if these methods are this sophisticated, catching them must be incredibly difficult.
It is.
What happens when the puzzle pieces finally fit together and someone is caught? Because this isn't just a slap on the wrist or getting called into the manager's office to get fired. The stakes are life-altering.
Oh, they are catastrophic. Drug diversion is a felony.
Yeah.
It leads to criminal records, the complete loss of your nursing license, and heavy involvement from the DEA.
The Drug Enforcement Administration.
Exactly.
We know from practice there are some specific case studies that really ground this in reality.
Yeah.
There's a case of a nurse we'll call Sarah. She was working in a nursing home and was caught swapping hydrocodone pills for Tylenol. She pled guilty and got 3 years of probation. But here's the part that just blew my mind. The State Board of Nursing let her keep practicing.
Which is a massive, dangerous systemic failure. Because they didn't revoke or suspend her license to mandate treatment, they essentially rubber-stamped her behavior.
Wow.
She was given 9 more years of direct access to vulnerable elderly patients before she was inevitably caught again.
Then there is Sally. Her case shows the brutal weight of the law. She was caught diverting fentanyl from the floor stock. She was terminated, the police were called, and she was charged with 26 felony offenses.
26.
They charged her with 1 felony for every single ampule of fentanyl she diverted.
Think about the gravity of that for a second. 26 felonies. She lost her job. She lost her health insurance.
Or how do you even recover from that?
You don't easily. She couldn't afford COBRA, which is that incredibly expensive temporary insurance you can sometimes buy to continue coverage. So she had absolutely no way to pay for the intensive rehab she desperately needed. And she was branded with a criminal record that would haunt her for the rest of her life.
It's a complete free fall. I mean, you lose your livelihood, your professional identity, your ability to get health care, and you are staring down the barrel of federal prison. It completely explains why they try so incredibly hard to hide it.
It really does.
But it also ripples out beyond just the nurse, doesn't it? What about the hospital?
The liability for the facility is astronomical. There was a well-documented case where an anesthesiologist overdosed on Demerol they had stolen from the hospital, right there in the call room.
Oh my gosh.
They died. And the family turned around and filed a $12 million malpractice lawsuit against the hospital for failing to properly secure their narcotics. The damage destroys the diverter, endangers the patients, bankrupts facilities, and shatters the trust of the community.
Okay, so if the consequences are this severe felonies, lost licenses, million-dollar lawsuits, it makes total sense why a bedside nurse would hesitate to report their coworker.
Right.
Because if I see a veteran nurse acting sketchy, my first thought is going to be, I don't want to be the reason this person's entire life is ruined.
And you are not alone in feeling that way. Research shows that 57% of nurses wouldn't want to confront or report a peer.
Over half.
Yeah. They fear retaliation, they feel like a tattletale, or they just don't want to carry the guilt of destroying someone's career.
Reporting a veteran nurse feels like pushing them off a cliff.
But that is the exact mindset shift we have to make at the bedside. They're already falling off the cliff. The addiction has already pushed them. Reporting them is actually throwing them a parachute.
That's a great way to look at it.
Because staying silent is what kills careers, and more importantly, it kills patients and nurses. The American Nurses Association Code of Ethics is not ambiguous about this. It explicitly states that nurses have a mandatory ethical obligation to protect the patient and report impaired practice.
It is not a suggestion.
No, it is your professional duty.
So, practically speaking, let's say I am at the bedside and I suspect a colleague is diverting. What is my actual chain of action?
First and foremost, you ensure patient safety. If you believe a nurse is impaired on the floor right now, you step in and protect their patients immediately. You do not let them administer another medication.
Okay, stop them from giving meds.
Second, you document objectively. Don't diagnose them in your notes. Just write the facts, what you saw, what the medication counts were, what the patient's pain levels were. And third, you report it to the charge nurse or unit manager immediately.
And what about the wastes? Because we talked about the waste loophole earlier, and this seems to be where so many innocent nurses get pulled into the crossfire.
This brings us to the absolute golden rule of nursing practice. Never, ever do an unwitnessed waste.
Even if it's your best friend on the unit.
Especially if it's your best friend. If a colleague says, hey, I wasted that morphine down the sink a minute ago, can you just sign off in the computer? Your answer must be a firm, uncompromising no.
Wow, okay.
If you scan your fingerprint and sign that computer without physically watching the liquid leave the syringe and go into the bin, you are officially an enabler. You are participating in the diversion, and you are putting your own hard-earned license on the line for their addiction.
But I want to inject some hope into this conversation, because earlier we talked about 26 felonies and ruined lives, but reporting someone doesn't always mean sending them to prison, does it?
No, it doesn't. And this is the part newer nurses really need to understand. Many states have what are called Alternative to Discipline, or ATD programs. These are absolute lifesavers.
How do they actually work?
If a nurse is reported and gets help, they can enter an ATD program. These are non-disciplinary, board-monitored recovery programs.
So it's about recovery, not just punishment.
Exactly. The goal of a hospital's diversion response team isn't just to punish people. It is to initiate an assessment and get life-saving treatment for a colleague who is suffering from a very real medical illness.
That's incredible.
Through these ATD programs, nurses can recover, they can keep their licenses, and after a period of monitored supervision, they can safely return to practice.
So speaking up can actually save their career, not end it.
Exactly. It is the most compassionate thing you can do for a colleague who is drowning.
Okay, let's bring this all together. Substance use disorder is a chronic brain disease that affects nurses just like anyone else. But our open daily access to controlled substances makes it deadly.
It really does.
We have to be hyper-vigilant for the subtle behavioral clues at the bedside. The waste buddies, the overly helpful narcotic fairies, the frequent long trips to the bathroom, and the patients who are mysteriously always in pain despite the charting.
And we have to remember that addiction thrives in the dark. It relies on secrecy and the hesitation of good people to speak up.
I want to leave you with that one firm, non-negotiable bedside rule we just talked about. Never, ever cosign a medication waste that you did not physically watch happen with your own two eyes. protecting your license protects your patients.
It is the simplest and most effective boundary you can set to protect yourself, your patients, and the integrity of your unit.
But I also want to leave you pondering this final thought today. If addiction thrives in secrecy and shame, are our unit cultures actually making it safe for a nurse to say, "I need help," before they steal that first vial?
That's the real question.
Or are we so hyper-focused on policing the medication cabinets that we are completely forgetting to check on the human beings who are using them?
That is the real work of nursing leadership and peer support. We have to care for each other as much as we care for the patients.
Remember, the goal of this conversation is to help you learn how to think, not just what to memorize. Head over to YouTube right now to watch the comic book video for this episode on Super Nurse Comics.
Yes, definitely check it out.
Make sure to like, subscribe, and leave a comment down below on what surprised you the most. Finally, visit supernurse.ai for amazing resources to help you become the super nurse you were born to be.
Keep looking out for your patients and keep looking out for each other.